Thank you. So I'm Natalie Berger. I'm one of the breast and GYN medical oncologists here at Mount Sinai West. Thank you for having me today. I'm very excited to give you all a talk on breast cancer. It's kind of designed as a breast cancer 101, but a little bit more in detail for what you need to know as residents, and hopefully also help you with board studying and what you might need. I'm a little far away from that now, so I was trying to remember the kind of questions from MixApp. I don't have access to it anymore, but hopefully this will be helpful. So if you have any questions, please let me know. I just want to say thank you to Dr. Lexi Berwick and Brittany Zimmerman, who shared slides with me to put this presentation together for you all. So general information about breast cancer. The average age of diagnosis is 62 years old, and the lifetime risk in women for developing a breast cancer is about 1 in 8, which is about 13%. The standard screening recommendation for breast cancer detection through mammogram is very controversial. We'll go into it a little bit, but the standard screening age is 40 to 45. My recommendation is 40. And an MRI if patients have a BRCA mutation, and we'll go into that a little bit more. Clinical risk factors for developing breast cancer include advancing age, obesity, tall height, and dense breast tissue. Estrogen exposure, so women who go through early menarche or late menopause, or nulliparous or have later pregnancies, no breastfeeding, taking oral contraceptive pills, receiving IVF, or having hormones after menopause are all risk factors. Other exposures may also increase the risk, including alcohol, radiation, tobacco. Genetic risk factors include a family history. So Ashkenazi Jewish descent is associated with a higher risk of different genes, including BRCA1 and BRCA2, but also other ones like CHEK2. High penetrance genes include BRCA1 and BRCA2, PALB2, Li-Fraumeni syndrome, which is TP53, P10, STK11, Peutz-Jeghers, CDH1. Those are all high penetrance genes, and those patients have a significantly increased risk of breast cancer. And moderate penetrance genes include CHEK2, ATM, and neurofibromatosis 1, NF1. So for patients with a BRCA1 or BRCA2 gene mutation, their lifetime risk of developing a breast cancer with BRCA1 is between 50 to 85%, depending on the study. For a BRCA2 mutation, it's between 45 and 65%. So in terms of statistics, breast cancer is the second leading cause of cancer death in women after lung cancer. In the US, it's the second most common cause. In the world, I think it's the first most common cause. In 2017, there were 252,000, almost 253,000 new cases of breast cancer in women in the US, and almost 41,000 deaths. The lifetime risk, as we had discussed, is almost 13%. It's about 1 in 8 women, and the median age of diagnosis is 62. So breast cancer screening, this is really important because even in residency and beyond, as primary care doctors, you're going to be ordering breast cancer screening for your patients. And patients are going to ask, what age should I start receiving mammograms? And these guidelines are controversial, and we'll go through a little bit about what the different screenings are. Overall, studies have shown that screening benefit, there's about a 20% reduction in the risk of breast cancer associated mortality through mammogram screenings. In women ages 39 to 49, there's a 12% reduction, and 50 to 59, about a 14% reduction, and it goes up to 33% in women the age of 60 to 69, and 20% in women ages 70 to 74. So the biggest benefit is between that 60 to 69 age range, but it's still significant regardless of the age. There was one trial, the Canadian National Breast Screening Study, that showed no mortality benefit among women ages 40 to 49 years old, which kind of stemmed this, pushing it towards 50. But as a breast medical oncologist, it's one study, and we see breast cancer, unfortunately, in women 40 to 50, and there is a benefit in reduction of mortality. So I strongly recommend starting at 40, but having a discussion with patients about the pros and cons, which is always so important to discuss pros and cons, because there are several. The pros are, of course, picking something up at an early stage where it's highly curable, and we'll go into the numbers of, cure rates based on stage. Some of the cons are that you may find something that's looks suspicious on mammogram, and a patient may undergo an unnecessary biopsy and it comes back benign. And so putting patients through more screenings, more biopsies when they have benign lesions, and the younger you are, the more of a chance you may pick up a benign lesion. So whose guidelines is it anyway? Different organizations have different guidelines. The American Cancer Society and ASCO recommend a starting age of 45 with the option to start at 40 and having a conversation with your patient. Between the ages of 40 to 54, it should be done annually. 55 or over, there is the talk of doing it every other year with the option for annual. I recommend annual mammograms. Again, you know, these cancers can develop on short interval imaging. We see it all the time, and maybe I'm a little biased, but the data does support doing it annually. Several of our organizations do recommend doing it annually, including ACOG and the NCCN guidelines, starting at the age of 40, which is what we do recommend to our patients. In terms of stopping ages, that is also different among the different organizations. As long as a patient has a good health, a good life expectancy, they can tolerate treatments, you know, whether it be, you know, endocrine therapy or chemotherapy, as long as they have a life expectancy greater than 10 years, you know, that's something to consider to continue. And that's another question that certainly as primary care doctors, it's important to know, because sometimes we'll get a patient who's, you know, 90, 95 years old. They're found to have a new breast cancer, and you know, their comorbidities, it would be impossible to give them the proper treatment. So it is important to have conversations with patients about when the right time to stop also is. And so that should be your shared decision making and considering their comorbidities. The USPSTF came out with the recommendation for 50 many years ago, but now they did say, you know, 40 to 49 through shared decision making. So what do we do? What are the risks and benefits and the harms? There was an expert commentary done and written in 2017. And basically, the overall consensus is screening starting, you know, between 40 to 50 every 1 to 2 years, reassess at the age of 70 and continue if their lifespan is more than 10 years. So screening guidelines. For women with a family history of breast cancer, the guidelines are a little bit different. So annual mammograms should start no later than 10 years before the age of earliest onset of breast cancer. And an ultrasound should be considered in women who have dense breasts. So basically, the younger the patient is, the higher chance that they are going to have dense breast tissue. And it's harder to detect an early breast cancer on mammograms because of this, and calcification may not be picked up or a speculated lesion. So ultrasound should be considered along with mammograms in these patients. Patients with a BRCA mutation, 1 or 2, who don't have risk-reducing surgery, which is a bilateral mastectomy, should undergo annual MRI starting at the age of 25. Beginning at the age of 30, they should start having mammograms. And the reason why it really shouldn't be done sooner is because the breast tissue is just too dense and you really can't read them well. At the age of 30, you can start mammograms usually with an ultrasound, because mammograms alone are really too hard to interpret at that age. For patients with a BRCA mutation, understanding how to do self-breast exams and breast awareness is very important starting at the age of 18. And they should have in-person breast exams starting at the age of 25 every 6 months to every 6 months to year. If a patient is getting both MRIs and mammogram ultrasound screenings, you should stagger them. So it's every 6 months that the patient is getting screenings and not getting the ultrasound and the mammogram at the same time each year. So warning signs and symptoms of breast cancer. How do patients present? So a patient may come into your office and say that they feel a palpable lump. They're not sure if it was there before. There may be a lump in the lymph nodes. Skin changes are important to look out for. Nipple discoloration or inversion. Some patients have nipple inversion, and that's their normal breast architecture. So it's important to ask if it's new or not. Weight loss and abnormality on screening mammography may also be a way that they present. So it's very important to do a breast exam at least every year on patients with their primary care doctor as well as their gynecologist. So hopefully they're getting at least 2 exams a year. So breast cancer survival is excellent. And I want to emphasize this because you guys see a lot of our patients and a lot of our curative intent patients who may come in because of a chemotherapy toxicity or something else. When a patient has localized disease, their 5-year survival is 99%. Regional disease is 85%, so lymph node involvement, and distant disease is 27%. But that number is even better now. For patients with metastatic disease with our newer therapies, these patients can live up to 10 years and beyond, especially patients with estrogen receptor positive breast cancer or hormone receptor or HER2 positive breast cancer. And we're going to get into those different subtypes in a little bit. So this is really, really important to remember in our patients with breast cancer. Survival outcomes are excellent. So even if somebody comes in and they're not doing so well, and you may think, wow, this patient looks pretty bad, maybe we need a palliative care consult. That's really not the case a lot of the times because our patients do excellent. So breast cancer pathology. Breast cancer cells develop into malignant cells from normal breast cells. These cancer cells can come from either the lobules, this is where breast milk is made, or it can start in the ducts of the breast, and that's where the breast milk is channeled down to the nipple. There can be lobular carcinoma or ductal carcinoma, and that's what those two terms mean. Lobules, the cancer cell started in the in the lobules, and ductal carcinoma means they started in the ducts. Around the lobules and ducts are the fatty connective tissue, and that's when the cells become invasive and they spread into the fatty connective tissue surrounding the lobules and the ducts of the breast. So breast cancer pathology. Breast cancer cells develop into malignant cells along a spectrum. So atypical ductal hyperplasia or atypical lobular hyperplasia are pathologic diagnoses. A patient may present with an abnormal mammogram or ultrasound and have a biopsy, and this may be what's seen. These are benign lesions of the breast, but they are associated with an increased risk of developing breast cancer in the future. So these are patients who we have discussions with about potentially taking risk-reducing medicines like tamoxifen if they're premenopausal, or an aromatase inhibitor if they're postmenopausal. We'll talk about those medications in a little bit as well. But they are not malignant. So that's important to remember. Then there's ductal carcinoma in situ and lobular carcinoma in situ. These are basically transitional stages. They are cancerous cells, but they're not invasive. DCIS is staged as stage 0. And they're termed precancer, which is a little bit of a controversial issue because it's not invasive and it kind of gives patients more anxiety when they hear that word. But this is, a highly treatable lesion, and it's good to find because you want to remove it before it becomes invasive. Because once a breast cancer cell is invasive, this cell has a potential to invade outside of the breast and become metastatic. So the breast cancer receptors. Hormone receptors are called estrogen receptor and progesterone receptor. Patients may have one or both of these receptors. And HER2 receptors is the third receptor that we look for on the surface of breast cancer cells. There are 4 types of breast cancer. So when you hear breast cancer, it's kind of an umbrella term, and every single subtype of breast cancer is treated differently. And that's very important to remember because, of course, the treatments are different, but the prognosis is different, and how we manage them in terms of the therapies that we recommend are different. And we'll get into that as well. So one of the subtypes of breast cancer is called HR positive or hormone receptor positive, which is talking about the estrogen and progesterone receptor, HER2 negative, and that's what we call hormone receptor positive breast cancer. Another type is hormone receptor negative and HER2 positive breast cancer. So that's HER2 positive breast cancer, where the HER2 protein is overexpressed on the surface of the breast cancer cell, but not the estrogen or progesterone. When we say triple negative breast cancer, that means that the patients don't express the estrogen receptor, the progesterone receptor, or the HER2 receptor, thus the triple negative subtype. And then the 4th subtype is triple positive. So they express both the hormone receptors and the HER2 receptor. So these they're proteins on the surface of the cancer cell, and they're involved in the growth signaling pathways. So basically, if the estrogen receptor is positive, this acts like a stoplight that's stuck in green. And that tells this cancer cell to grow and divide over and over again, and it becomes a tumor. With the HER2 signaling, it's a tyrosine kinase activation, and there's signal transduction of multiple different pathways, the PI3K kinase and the RAS pathway. And this results in DNA transcriptional pathway, and then these cancer cells divide over and over again. The positivity is determined by different kinds of tests that our pathologist does. IHC is immunohistochemistry, and these are stains that are done on the slides that are made after a biopsy. And based on the IHC staining, the pathologist labels these cancer cells as either positive or negative for the hormone receptors. And also the HER2 receptor is first assessed by IHC. Receptors are always written in a specific order. So first comes the estrogen receptor, then the progesterone receptor, and then the HER2 receptor. So if you ever see somebody write something, positive, positive, negative, or negative, negative, positive, it's always estrogen receptor first, progesterone receptor second, and HER2 receptor third. 70% of breast cancers are hormone receptor positive. So this is the most common subtype that you see. 20% are HER2 positive and 10% are triple negative. Triple negative is the most aggressive subtype because we don't have any targeted therapies, but the landscape is changing and in the last year has changed tremendously. So we will go into that a little bit. So the definition of hormone receptor positive, as we talked about, it's the estrogen receptor and the progesterone receptor. So hormone receptor low is basically when the breast cancer cells express the estrogen or progesterone receptor and 1 to 10% positivity. This is something that the pathologist reports when they look at the cancer cells under the microscope and how much of that stain they take up. 1 to 10% is still considered positive. Anything greater than 1% is considered positive, but we know from studies and looking back that patients who express the estrogen receptor from 1 to 10% and are considered low expressors behave more like a triple negative breast cancer. Greater than 10% is considered positive. The definition of HER2 positive is a little bit more complicated. HER2 is also graded by IHC from 0 to 3, actually. 0 being that none of the cells take it up. 1+ is very few. 3+ means that the stains, really take up the stain, and that is considered positive. So if you see on a pathology report HER2 IHC 3+, that's considered positive, and these patients do not need FISH testing. When a patient has HER2 IHC 2+, that's considered equivocal, so it requires confirmatory FISH testing to say whether this cancer truly overexpresses the HER2 receptor. And that's done through FISH, which is fluorescent in situ hybridization. And that looks at the HER2 and CEP17 and the HER2 copy number on chromosome 17. And basically it looks at the ratio of these two, and if it's greater than 2, that's considered positive. And if the HER2 copy number is greater than 6, considered positive. And so this is done through a different lab, and that usually comes back as an addendum after the initial IHC stain, and it takes there's a 2-week turnaround time to get FISH testing. But this is very important. The guidelines are to do FISH testing on IHC 2+, not on 1+, but we have found that in 1+, sometimes they do come back positive by FISH, so sometimes you will see FISH sent on 1+. So breast cancer staging and prognosis. So staging takes into account whether patients are hormone receptor positive or HER2 positive, because these patients do have a better prognosis than patients who have triple negative breast cancer. And I think the boards does test based on size and lymph node status. So, there probably won't be too many questions. So it's all about how much you want to memorize, but it is just something to be familiar with because across cancer types, there are similarities in the T and M staging system. So the T is the size of the cancer, the N is the lymph nodes, and then M is whether it's metastatic or not. So for breast cancer, a T1 lesion is broken up into T1A, B, or C, depending on the size. T2 is 2 centimeters to 5 centimeters, and a T3 is anything over 5 centimeters. T4 means that there's invasion of the chest wall, skin involvement, or inflammatory breast cancer. For lymph nodes, N1 disease means that there's 1 to 3 positive axillary lymph nodes. And this is very important when it comes to some of our treatments because the lymph node status really dictates how we treat a patient and whether a patient needs chemotherapy or not in patients who have estrogen receptor positive breast cancer. N2 is 4 to 9 lymph nodes and N3 is 10 or more. Or involvement of supraclavicular lymph nodes, and M1 is distant disease. Cervical lymph nodes are considered M1 disease. Prognosis varies significantly based on whether, the staging is early or late in the receptor status. So patients with stage 1 to 3 breast cancer, the 5-year overall survival, as we discussed before, is between 80 to 95%, depending on whether lymph nodes are involved. With hormone receptor positive breast cancer, the 5-year overall survival is 95%. HER2 is 85%, and triple negative is 75%. So again, you can see the difference in prognosis between these subtypes of breast cancer. In metastatic breast cancer, in stage 4 breast cancer that's hormone receptor positive, the 5-year overall survival is about 30%, which is much better than most cancers. In HER2 positive, it's about 20%, and in triple negative, it's about 10%. So again, you can see in terms of prognosis that the triple negative breast cancers have the worst overall prognosis. So early stage breast cancer treatment. So again, this is how we talk about the continuum. So patients who have ADH or ALH, the atypical lesions that are benign, treatment modalities usually include surgery. So these patients usually go for a lumpectomy to make sure that there is no invasive component or, higher grade lesion like DCIS or LCIS. And then after surgery, they'll meet with a medical oncologist to discuss endocrine therapy, which is usually tamoxifen or an aromatase inhibitor, but can also include some other medications that I talk about in a little bit. And then there's DCIS, and these patients usually have surgery. With DCIS, these patients are usually also treated with radiation and then endocrine therapy as well. Oh, sorry. However, if a patient has DCIS and gets a mastectomy, that is considered curative. But sometimes we will also discuss endocrine therapy for those patients, but after a mastectomy, patients with DCIS don't need radiation. LCIS is a benign lesion. Those patients do not get radiated. They'll go for a lumpectomy, and then we'll talk about endocrine therapy. For invasive breast cancer, the treatment usually involves surgery, radiation, endocrine therapy if they're hormone receptor positive, plus or minus chemotherapy, depending on the subtype. So the goal for treatment for early stage breast cancer is local control, right? Remove the cancer locally. And that involves surgery, and radiation is also local therapy. It's to prevent a recurrence either in the breast or the lymph nodes. Systemic therapy is what I do. That's to reduce the risk of local and distant recurrence. Distant recurrence is a stage 4 recurrence, which is no longer curable. And of course, we want to prevent as much as we can. So the purpose of systemic therapy in early stage breast cancer is, number 1, to destroy any microscopic cancer cells not removed during the surgery. And number 2, is to modify the hormonal environment to reduce the risk of recurrence. And that may involve one of 3 modalities, which is chemotherapy, endocrine therapy, and antibody therapy, again, which is depending on the subtype. So chemotherapy is cellular poison. It kills rapidly dividing cells. It also kills our normal cells and is associated with many different side effects. Endocrine therapy is anti-estrogen hormone therapy. It reduces estrogen in the body that would stimulate the estrogen receptor on cancer cells. So it's basically removing that food source, that signal that's telling these hormone receptor positive breast cancer cells to grow and divide. Antibody therapy is directed at the HER2 receptor, and it prevents the downstream signaling pathways of these cancers and is extremely, extremely effective. Other therapies may include conjugated antibodies, CDK4/6 inhibitors, PARP inhibitors. We're also using immunotherapy now in breast cancer. So surgery, as we talked about, either involves a lumpectomy or a mastectomy, depending on the size of the tumor. So for early stage breast cancer treatment, chemotherapy, if it's needed, is either given before surgery, which is called neoadjuvant therapy, or if it's given after surgery, it's called adjuvant therapy. So the reason when neoadjuvant therapy is given, the chemotherapy or sometimes estrogen therapy is also given before surgery, or antibody therapy. The goal is to shrink the cancer with the goal of the cancer disappearing completely so that at the time of surgery, no residual cancer cells are seen. This most commonly happens in triple negative breast cancer and HER2 positive breast cancer. In estrogen receptor positive breast cancer, it's very unlikely to have a complete response where there are no remaining cancer cells at the time of surgery, just because these cancers have a lower proliferative index. They don't grow and divide as quickly, and so they are not as sensitive to chemotherapy as the triple negative and HER2 breast cancers. This is a question that you may be asked on oncology rounds. I don't know if the boards would ask this, but the subtype of breast cancer that's most sensitive to the neoadjuvant chemotherapy is HER2 positive breast cancer that's hormone receptor negative, because these antibody therapies, these HER2 drugs that we're going to talk about, are so effective when combined with chemotherapy. And in some of the studies, up to 80% of patients have a complete response at the time of surgery if they have the hormone receptor, and if they have the HER2 receptor only. For patients who get neoadjuvant treatment, they get the upfront chemotherapy or antibody therapy, surgery. Then they proceed with radiation therapy in many cases. And then that's followed by endocrine therapy and or antibody therapy, depending on the subtype. If patients get adjuvant therapy, then they get surgery first. That's followed by the systemic therapy, the radiation, and then the other systemic therapies. So how do we choose adjuvant versus neoadjuvant therapy? Neoadjuvant therapy, the goal and the reason to do that are a few things. Number one is downsizing the cancer, because if you have a large cancer that wouldn't allow for the surgeon to do a lumpectomy, by giving the chemotherapy or antibody therapy up front, you can make this tumor smaller and allow for the patient to have breast conservation surgery, which is a lumpectomy. It can also downstage the axillary lymph nodes. So if a patient has several axillary lymph nodes, they may need an axillary lymph node dissection, which is basically removing many, many lymph nodes from the arm. And that can be associated with lymphedema, which is extremely morbid. And so by giving this therapy up front, it may allow the surgeon to just do a sentinel lymph node biopsy where they just remove a few lymph nodes. The other reason to do neoadjuvant therapy is because you can assess their response to therapy in real time and see if they're responding, and you can tailor their adjuvant therapy, their therapy that they get after the surgery, depending on whether they had a complete pathologic response, which we call PCR, or not. For triple negative breast cancer and for HER2 positive breast cancer, we now tailor our therapies, whether a patient has a complete response or not. So if a patient has a complete response, then for HER2 positive disease, we continue the same antibodies on the back end to complete 1 full year. However, if they don't have a pathologic complete response, we actually change their antibody therapy after surgery. For triple negative breast cancer, if a patient doesn't have a pathologic complete response, we may recommend a medicine called capecitabine or Xeloda after the surgery. And now at ASCO this past year, 2021, a PARP inhibitor called olaparib was also approved for patients with triple negative breast cancer who have a BRCA mutation. So now, depending on how a patient responds and their risk of cancer, we have other therapies that we can give them to try and cure them. Neoadjuvant therapy is used in almost all cases of triple negative breast cancer and HER2 positive breast cancer, but it depends on the size. So we're not going to go into those nuances. So the early stage systemic treatment schema, all invasive breast cancer gets chemotherapy, except patients who have hormone receptor positive breast cancer and low risk. Low risk means these patients have a low risk determined by a genetic recurrence score called an oncotype or a mammoprint. If you guys have rotated with us in clinic, I'm sure you've seen these scores, because being that hormone receptor positive breast cancer is the most common breast cancer we see, and most patients we do detect at an early stage, we send these scores on all of our patients who have an early stage hormone receptor positive breast cancer. Oncotype and mammogram are genetic recurrence scores. This is the cancer's genetics, not the patient's genetics. It's used in hormone receptor positive breast cancer to determine if endocrine therapy alone is sufficient and whether we can eliminate chemotherapy. It used to be that all patients with hormone receptor positive got chemotherapy, and then we realized we are way over treating many of these patients, and that's how these gene panels were developed. So Oncotype is a panel that has 21 genes which predict for a likelihood of recurrence. It's used in both node positive and node negative breast cancer. For node positive breast cancer, it's only patients who have 1 to 3 positive lymph nodes. In any hormone receptor positive breast cancer with 4 or more lymph nodes, we do not send this assay. There are also several other caveats for the Oncotype. We send it in all patients, whether they are pre or postmenopausal, who have a hormone receptor positive node negative breast cancer. They all get an Oncotype. For these patients, if their score is 25 or less, we do not recommend chemotherapy, and we recommend endocrine therapy alone. A score of 26 or more means that we do recommend chemotherapy. But the caveat is that in premenopausal patients who have a score of 16 to 25, there is more of a discussion about benefits to chemotherapy, which is usually not what we recommend. But we do discuss ovarian suppression, which means giving them an injection to chemically suppress their ovaries so that we can give them an aromatase inhibitor. The different pills that we use for the treatment of breast cancer are tamoxifen, And then the aromatase inhibitors. The aromatase inhibitors, there are 3 different pills that we use: anastrozole, letrozole, and exemestane. They are all essentially the same in their mechanism, and they've never really been compared head to head. So which one is used is kind of oncologist dependent. But these pills can only be used if you're postmenopausal. And the reason is tamoxifen works at the level of the estrogen receptor itself. So when a patient takes tamoxifen, it's metabolized in the liver to a prodrug. And then that prodrug is what acts at the level of the estrogen receptor and blocks it to block a patient's estrogen from binding to that receptor and telling this cancer cell to grow and divide. So that pill can be used in pre or postmenopausal women because it doesn't matter how much estrogen is circulating because it works at the estrogen receptor. The aromatase inhibitors actually work by preventing our fat cells from making estrogen from androgens. And so this pill is only effective in postmenopausal women because even if you're blocking the fat cells, premenopausal women are still getting estrogen from their ovaries, which is the predominant source of estrogen. So it really doesn't do anything. So the only way to be able to give a premenopausal women an aromatase inhibitor is to suppress their ovaries, either chemically or by removing them. And the reason why we would want to do that is because tamoxifen has been compared head to head to the aromatase inhibitors, and the aromatase inhibitors are more effective at preventing breast cancer recurrence. So in these patients who have a higher oncotype, defined as 16 to 25, based on many other factors as well, which are beyond the scope of this conversation, we sometimes, or with 21 to 25, we pretty much always have the conversation of ovarian suppression with an aromatase inhibitor. In node positive, it's even more complicated, but for postmenopausal women who have 1 to 3 positive lymph nodes and an oncotype score less than 25, we can now say, based on a study called RxPonder, which was presented in abstract form at San Antonio last year, that we can eliminate chemotherapy and only recommend endocrine therapy. For premenopausal patients, there was a signal that there's a benefit to chemotherapy regardless of the score. This is extremely complex. You'll never be asked this. And even in the oncology community, there's some controversy around this. So we're not going to go into that. Mammogram is another genetic recurrence score, and it's a 70 gene panel and can be used in node negative or node positive breast cancer. And that basically comes back as either low risk or high risk. Patients who have a low risk mammogram do not require chemotherapy, and a high risk mammogram, we do recommend chemotherapy. So receptor therapy is the backbone of all of our treatments. And this is why the patients do so well. So with hormone receptor positive breast cancer, like we talked about, we recommend endocrine therapy. I don't like calling it hormone therapy because when you tell patients, it's a hormone, they get a little worried because hormones are associated with, people have different definitions of what a hormone is. And it's really an anti-estrogen, right? It's to reduce the levels of circulating estrogen. And this pill is usually recommended. It's a pill that they take once a day, every day. It's recommended for 5 to 10 years. The 10-year is also a little bit controversial, and the data is continuously evolving, and it's a very individual decision on whether to extend therapy beyond 5 years. For HER2 positive breast cancer, the antibody therapy is the backbone of this therapy. HER2 and hormone receptor triple positive breast cancer, these patients get the anti-estrogen therapy and the HER2 antibody therapy. For triple negative breast cancer, there are no targeted agents, unfortunately, but we are making progress. Immunotherapy, pembrolizumab, was just approved for the treatment of triple negative breast cancer, for high-risk triple negative breast cancer, I should say, for patients who have a T2 tumor, so a tumor greater than 2 centimeters inside, or lymph node positivity. And it's given in combination with the chemotherapy and then following surgery for 9 more treatments. And that was associated with an improvement in the pathologic complete response rate and the event-free survival. So basically the patients who received the pembrolizumab group had less cancer coming back at the first data cutoff, but we still don't have overall survival benefit because it is newer data. And in breast cancer, or in all cancer studies, especially in the curative intent treatment, the most important endpoint is survival, right? Are these patients living longer or not? Because that's the most important thing when you're talking about exposing patients to more drugs, because they are associated with more side effects. So chemotherapy backbone regimens for the treatment of breast cancer. I think this is also talked about a little bit on boards, and they may ask you some questions about this. So the backbone chemotherapy regimens depend on whether patients are HER2 negative or HER2 positive. The HER2 negative chemotherapy regimens, there are 3 regimens that we typically use. One of them is called ACT, or you may see it written as dose dense ACT or C2 little d's before that ACT when you look at our notes. And that's comprised of 3 chemotherapy drugs, adriamycin and cyclophosphamide, which are given together for 4 cycles, and then it's followed by a 3rd drug called paclitaxel. TC is cyclophosphamide and docetaxel. So the T, they're both a taxane, but it's a different taxane. CMF is the combination of 3 drugs, cyclophosphamide, methotrexate, and 5-FU. This is our oldest regimen and used in certain cases. This one has a low risk of alopecia, hair loss. So for some patients, it may be recommended. We usually don't like to recommend it for that reason, but sometimes patients are like, there's no way. So sometimes we'll use it for that reason. It's also a little bit better tolerated than the other 2 regimens listed above. So for our older patients, this may be a regimen that we would recommend. For HER2 positive breast cancer, the different regimens are ACT-HP, which is this same ACT regimen, plus Herceptin or trastuzumab, and pertuzumab, which is Perjeta, is the brand name. TCHP. So the C in this is carboplatin, not cyclophosphamide, like in the HER2 negative chemotherapy regimens. So even though the initials are the same, they're different drugs, which is very important to know. And then HP. And then TH, which is a combination of docetaxel and Herceptin, which is trastuzumab. Important side effects to be aware of for some of these drugs. Adriamycin can cause irreversible cardiotoxicity. So all of these patients should have an echocardiogram before starting chemotherapy. Paclitaxel can cause neuropathy. It usually does improve with time, but you really have to monitor this closely. All of the chemotherapies that we give cause myelosuppression. So we monitor their white blood cells, red blood cells, platelets, and we check these before each chemotherapy. Hair loss, and all of our chemotherapies can cause infertility, which is very important because when you think about, breast cancer in our patients, we treat a lot of young patients, and it's very important to discuss fertility preservation also in male breast cancers in the younger patients because you can't go back. So it's very important to have that conversation with them. Some of our patients after the chemotherapy, they may resume menses, but it doesn't necessarily mean that they'll be able to get pregnant. So having, the eggs stored in advance is really important for them. So the hormone therapy. There are many different drugs. We discussed a little bit about the tamoxifen, anastrozole, letrozole, and exemestane. Raloxophene is another SERM, selective estrogen receptor modulator. Raloxophene is only used for chemoprevention, meaning the atypia, the ADH, the atypical ductal hyperplasia, atypical lobular hyperplasia. You could also consider it in DCIS or LCIS, but it is not used in invasive breast cancer. And that's because it was compared head-to-head to tamoxifen, and it's not as good. So never in invasive breast cancer. And then the aromatase inhibitors, which are the postmenopausal drugs, which inhibit peripheral conversion of fat to estrogen. So important side effects of these medications. The SERMs have a 1 to 2% increased risk of DVT. So whenever you're seeing a patient, it's important to ask them before starting these medications if they have a history of this. It's also important to alert them of it and to notify you if they ever have any changes, swelling in one leg and not the other, calf tenderness. There is also a low risk of endometrial cancer. We quote them about 1%. And the reason why is because in the breast cells, these pills are anti-estrogen. They block the estrogen receptor, but in the uterus, it's actually pro-estrogen and stimulates the uterine cells. So you can get uterine hyperplasia. And anytime you have hyperplasia of a cell growing more than it should, it can become invasive. Other important side effects to tamoxifen include hot flashes, night sweats, vaginal dryness, mood changes, weight changes. These are all potential side effects, and it really is individual how patients react to each of these medications. The aromatase inhibitors cause more arthritis and myalgias than the tamoxifen does, but both can do it. In terms of both of these medicines, the aromatase inhibitors can cause osteoporosis. They cause accelerated bone loss. So a patient may develop osteoporosis earlier in their life than they would have otherwise. For tamoxifen, in premenopausal women, tamoxifen also accelerates bone loss. So it's important to check a baseline bone density scan on your patients. For postmenopausal women who take tamoxifen, it's protective of the bones. So it's important to have these conversations with patients, because when you're talking to them, actually one of the side effects they are most worried about is osteoporosis, right? Because everybody knows somebody or has heard of a story of somebody, you know, or an older woman or male who falls and breaks a bone, and the morbidity and mortality associated with that is pretty significant. So it's very, very important to talk to your patients about this. The aromatase inhibitors can also increase cholesterol. So it's very important to check. I tell patients to check their cholesterol with their primary care doctor every 6 months to a year. The aromatase inhibitors can also cause hot flashes, night sweats, vaginal dryness, decreased libido, mood changes, weight changes. Some patients get nausea, dizziness. There's so many potential side effects, and you kind of don't know until a patient starts it. So the HER2 antibodies, those are given, so this is early stage breast cancer. The HER2 directed antibodies are given for 1 year total. So if they get it before surgery, they don't get it for another year after surgery. It's 1 full year. And trastuzumab Herceptin is always given. Pertuzumab is given sometimes. It's used with trastuzumab for patients who have T2 disease, so a tumor of 2 centimeters or more, or any positive lymph nodes. The combination of these two drugs can cause diarrhea, a lot of diarrhea in some patients. So that is something to alert the patients of and make sure they have Imodium at home before they start the chemotherapy regimen. TDM1, Kadcyla, is also sometimes used in the treatment of curative breast cancer. And the time where it's used is in patients who get neoadjuvant chemotherapy who don't have a pathologic complete response. So when they go for their surgery, there's residual cancer. These patients get TDM1 in the adjuvant setting for 13 cycles. Important side effects of these drugs. So these drugs can cause cardiotoxicity. But compared to adriamycin, where it's irreversible, with these drugs, it is reversible with holding the therapy. So with these patients, we check echocardiograms before treatment starts and every 3 months during treatment. Pertuzumab or Perjeta can cause diarrhea, and TDM1 can cause thrombocytopenia, transaminitis, and neuropathy. So in summary, here are the different regimens for the different types of breast cancer that we recommend for hormone receptor positive breast cancer in the adjuvant setting. Patients with a low oncotype, caveats being premenopausal women, a score of less than or equal to 25. We recommend endocrine therapy plus or minus ovarian suppression if they're premenopausal. Patients with a high oncotype greater than or equal to 26, they will be recommended to receive chemotherapy plus endocrine therapy. And we start the endocrine therapy after they complete the chemotherapy. For patients with HER2 positive breast cancer in the neoadjuvant setting, we have moved away from using the ACTHP regimen, because if you remember, the adriamycin, as we just discussed, causes irreversible heart failure. And when you combine that with the Herceptin, and Perjeta, which can cause heart failure, there's an increased risk of cardiotoxicity. And so these two drugs, these two regimens, the ACTHP and the TCHP, they've been studied in the same trials, but the endpoints were not to compare them head to head. But we have so much data now on these medications. For most patients, we really can eliminate the anthracycline and give these patients TCHP. For adjuvant therapy, if there's residual disease, after they get TCHP, we stop the HP and switch to TDM1. For patients without residual disease, after they complete the TCHP at 6 cycles for surgery, we continue the HP. For hormone receptor positive and HER2 positive, triple positive breast cancer, neoadjuvantly, usually it'll be the TCHP. If they have residual disease, it's treated the same way as if they didn't have the hormone receptor, except that these patients also will get endocrine therapy. And the endocrine therapy is overlapped with TDM1. For patients who are triple negative, we will usually give these patients neoadjuvant chemotherapy, and that is usually the ACT regimen. The ACT regimen was looked at in a study as to who benefits from it, and patients with triple negative breast cancer, whether they had negative lymph nodes or positive lymph nodes, had a benefit to the anthracycline. And now, what I had mentioned before is pembrolizumab. has been approved by the FDA to use in the neoadjuvant setting in combination with ACTC. So what this is adriamycin cyclophosphamide, the taxane paclitaxel, and this C is carboplatin, which is another regimen that we can use for the treatment of triple negative breast cancer in combination with pembrolizumab. Important to note is that when TC is used together, the paclitaxel and the carboplatin, the main thing that you see and the biggest problem with getting these patients through treatment is myelosuppression. For the adjuvant therapy in patients who have residual disease, who have triple negative breast cancer, we recommend capecitabine plus or minus continuation of pembrolizumab if they got it in the neoadjuvant setting. But important to note that capecitabine in combination with the pembrolizumab has not been studied yet. There is a study that looked at adjuvant pembrolizumab only, SWOG 1418, but we don't have the data on that yet. And the capecitabine was given first, followed by the pembrolizumab. For patients who have a pathologic complete response and no residual disease, usually the recommendation is observation. Unless they had gotten the pembrolizumab in the neoadjuvant setting, then we continue that adjuvantly. I think for the scope of this talk, we're going to skip metastatic because that's a whole talk in itself. So I'm going to end it here.
Thank you so much, Dr. Berger, for the great talk. Julia and I were talking, you can definitely see Lexi's influence as well, like in the presentation. We love how she helps organize things. We do have a couple of questions in the chat. So Faris was asking if for patients who are BRCA positive above age 30, is it like MRI plus mammogram after age 30?
Yeah, so it's MRI plus mammogram, and you want to stagger those so they're getting one study every 6 months. You don't want to do them at the same time.
Yeah, and we have one more question as well from Kirtana. She's asking, is there any evidence about dangers of radiation in case of annual mammograms starting at age 40?
So of course that is one of the concerns, but the radiation exposure from mammograms really is so low. Mammograms that involve tomosynthesis, you'll see that more commonly now because they are a better test, they do have a little bit more radiation, but if you would do a 2D reconstruction of that, the radiation dose really is so low. It's important to talk to patients about, so they're aware that these studies do involve radiation, but the exposure really is not, it's such a low dose of radiation that it shouldn't stop you from doing it.
Perfect. Thank you so much.
Sorry, for the BRCA question, just to go back to that, is the screening is to do that, but the recommendation for these women, and important to discuss with them, is a prophylactic mastectomy on both sides. So it's really, really important to talk to patients about this.